Hello and welcome to the Palliative Radiation Oncology lecture. I'm Ravi Chandra. In this lecture, we will broadly overview palliative radiation medicine in terms of its role and rationale in the care of typically non-curative patients. Remember that the term palliative really refers to being symptom-directed, so either symptoms that a patient is presently having or symptoms that they could have. It typically does not have an association with whether or not the treatment is curative, in as much as the treatment could be given during the course of a curative therapy approach, or it could be given alone. Now, typically, palliative treatments are given when a patient is not curable, and so they're really being focused on symptoms that patients may have in the course of advanced illness. And we will sort of schematize on the subsequent slides a little bit more what that looks like. But it is important to be aware that there are data for the use of palliative care, even in patients who are potentially definitive, meaning curative, and also patients who are early in the stage of their metastatic disease course, because many diseases can have long arcs of therapy. As I'll show you on the next slide, depending on the center that a radiation oncologist is working at, the palliative population could be as much as half of the patients they see, and in other cases could be closer to a third. But regardless of where you practice, if you do choose to practice radiation medicine, and also what subsite you might specialize in or not, palliative radiation oncology is a critical part of any of those positions. A final remark that I'll make by way of introduction concerns the nature of this sort of treatment. While we will discuss some of the symptoms that are driving the initiation of treatment, as I'll highlight to you, many of these symptoms are delivered in the context of new diagnoses, new episodes of care. Sometimes they are a new diagnosis of metastatic disease. Sometimes they are prompting a change in therapy. And so in some cases, you'll have longitudinal relationships with these patients where you'll see them many times over the years. Sometimes it'll be just briefly right before they go to hospice. But in any event, many of the skills that you've learned and will learn with respect to frameworks for talking to patients and having difficult conversations, interacting with patients and families, expressing hope but worry, using that sort of framework, especially when you're counseling patients on how to proceed. Things like this are all really, really critical aspects of the care of these sorts of patients, and in many ways, a more significant driver of these sorts of interactions than some of the radiation principles that we're going to discuss. So with that, let's just turn to the first definition of what palliative radiation oncology is. And I mentioned this in my intro remarks that palliative radiation, can be anywhere from 30 to 50% of the patients that we see. A model from one of the leaders in palliative radiation oncology, Tracy Balboni, sort of schematizes what a disease course might look like currently with respect to palliative radiation. And this was given in the context of a proposal for what the future might look like, but I'm really just going to focus here on some of the times that we might get involved in the care of these patients. Now, it might be at a new metastatic diagnosis that these patients will come to see us, and in many cases, they'll be coming to see us with maybe new symptoms or maybe the discovery of metastatic disease. And our role in this case is not only to address whatever symptom they're having, but it might involve discussing the diagnostic workup, treatment paradigms, survival statistics. These may be inpatients we see in the hospital. This may be outpatients. And the idea here is there's a lot of counseling as to, well, what might the future hold? As you can see here, and we'll talk about each of these, but, the role of the palliative radiation oncologist might be even if you're having longitudinal interactions, to interact with patients at discrete intervals, as opposed to the medical oncologist, who in this case may be interacting at a more continuous interval. This is as a contrast, or this is specific to palliative radiation. This model may be reversed in other types of cancers that we treat. I mention that because sometimes, just like if you're living in the same house as a family member, you might not notice a change that happens gradually, but if you're maybe a visiting family member and you come in every so often, you might see a change in a person. So it might be something like gaining or losing weight. It might be how much gray hair they have. It could be something else, right, that you may not notice on a particular day. And while these are simple examples, there is a real opportunity for the palliative radiation oncologist in this context to really be able to intervene at discrete points, take stock of where things are, and to help with some pretty critical counseling at these intervals. But really at this first time point that we're discussing now, it might be an education standpoint. It might be helping with the diagnostic workup. They may not even have seen a medical oncologist yet. It might be a very new diagnosis, and you're really addressing things at the outset. In terms of their overall symptom burden, even if there are significant symptoms that are prompting their treatment, they may be relatively low on the scale of overall symptomatology at this time point. Oftentimes, the mainstay of what will impact their life expectancy concerns systemic therapy. Systemic therapy, of course, goes to every nook and cranny in the body, and it might be that systemic therapy is helpful at allowing that patient to live longer when delivered in a palliative context. But like with many things, it only lasts for so long, and sometimes patients transition to other forms of systemic therapy, either due to failure or something else. As we've spoken in other talks, and we'll review again, cancer is a heterogeneous, not homogeneous process, especially when it spreads. So you might have a patient who has discrete mets from a cancer in different parts of their body, that despite the fact that on paper they all look similar, meaning that you take a CT scan or you take a PET scan even, they all look similar. And they may have all arisen from a common source, let's just say a thyroid source, for example. The genetic diversity, and they're constantly evolving and potentially themselves spreading new foci of disease. I think there's a really fascinating way to think about the biology of these sorts of tumors and evolving sort of in parallel to each other. It might be that a systemic therapy works really well at impacting or eliminating or decreasing certain sites, but maybe not at other sites that themselves continue to grow. And in terms of covering things like the treatment of oligometastatic disease, which I've described in a separate talk, it might be that there's a rationale for a different sort of therapy at this site in the curative management of patients. But in the palliative management of patients, it may be that some sites respond differently than others, and therefore, even in patients who are well receiving systemic therapy, it may be that some sites have discordant responses that ultimately require some treatment. It may be, though, that in time, even with palliative treatment, that the clones from this sort of tumor predominate, so that over time, what you end up seeing, regardless of whether you do palliative radiation, which remember is not curative, what can happen then is you now have not just one but multiple sites of predominantly, in this case, yellow disease. And in this case, this prompts perhaps a change in systemic therapy. That change in systemic therapy then in turn will help address these tumors, but it might be that one of them predominates, and instead of now having more yellow characteristics, it might be that certain brown characteristics predominate. And then in time, the same thing happens where what you tend to see are brown lesions. And so what you're really seeing over the course of time here is that each of these changes in systemic therapy are really sort of selecting for, much like you would in a test tube with antibiotic resistance, you're really selecting for different clones of disease. And prompting each of these is where the treatment-resistant clones have sort of overtaken the utility of whatever systemic therapy you are on. Of course, the ideal is that when you're treating with systemic therapy, that you're able to abolish all the clones, so there never is a brown or a yellow clone to predominate. But that doesn't always happen. And so part of the oligometastatic paradigm, I think, is thinking about ways to effectuate that. But under the current model, really what we tend to see are patients that are going through multiple lines of systemic therapy. And that the palliative radiation occurs usually when there's either a symptom trigger, so due to one of these lesions here, say, that is causing symptoms, or at a time where you're looking at a scan and you're seeing that the situation is changing and the systemic therapy is changing, we might be involved at that point. The problem is over time, the more courses of systemic therapy you receive, the greater the decrease in the patient's performance status. And this is their ability to do things, and their quality of life decreases because their physical reserve decreases. It takes a toll on them. It decreases their marrow. It causes other toxicities. In addition, as you go along this line, there are fewer and fewer effective cocktails available. Some diseases have more than others, and this line, this x-axis can be longer. Cases like prostate and breast cancer, sometimes the cancers themselves behave on a longer course, and sometimes we have more effective treatments that last longer, but for some cancers we don't. So as we go along here, the treatments become less effective, the patient's symptoms increase, their functional status is decreasing, and as we get closer down here, we start to see things like hospice, where patient's life expectancy is usually less than 6 months. Ideally, we would know when this time point is. The problem is when you are this guy or gal, sometimes you don't necessarily know if this patient is here or here or here. You know after taking care of enough patients on average, but sometimes we have a hard time estimating when this is going to happen. It's sometimes hard to know. So sometimes we think about it too early, and in many cases we think about it too late. So this is all a long way of saying that radiation oncologists can be helpful because they intervene at discrete time points. They often intervene during times of sort of high anxiety due to changes in treatment, and potentially can provide a useful external viewpoint in a way, even in the context of an established relationship with a patient, of helping to have discussions that might impact the future. And of course, there's a lot of data about the value of seeking hospice care at an appropriate time point in terms of quality of life and how patients die. How patients die, by the way, is a complicated and interesting topic, especially when it comes to cancer. And it's one that's outside the context of this particular talk, but one that I'd be happy to discuss with interested students. Okay, it's a really great review, which I've put a picture of down here, and it's in a book we wrote recently, and this is co-authored by Josh Jones, who's a terrific radiation oncologist and palliative radiation oncologist at the University of Pennsylvania. And I have here a few slides, a few pictures with slides that they had used as figures, which I think really sort of hit at some of the things that I discussed in words on the previous slides. But when we kind of think about, first of all, the use of palliative radiation therapy, we think about, first of all, are we looking at simpler, kind of shorter types of treatment? Are we looking at potentially higher dose, more complicated treatments. This is all in the context of palliative radiation, right? So let's just for instruction's sake, let's just say, the typical dose for a curative treatment can be anywhere. Remember, all of our doses are in gray. Typical dose for a curative treatment is usually in the 60 to 80 gray range, plus or minus chemo. Sometimes if surgery is given, then this might be more in the 50 to 60 gray. But oftentimes, things that are in this range tend to be more curative. Whereas things in the palliative range may be as high as 40 gray, but usually 30 or less. The idea here is that should be enough to be able to kill tumor so that symptoms are improved, but it's not enough to eradicate a particular tumor altogether, and it may be that it grows back. In some patients who are going to live a long time, it might make sense to use a little bit higher dose for some increased durability. And by contrast, in patients who are not going to live as long, you might use lower doses, like maybe even 5 gray range. The complexity of treatment as well drives the impact of how long it takes to start that treatment. So more complicated treatments tend to take a little bit more time to plan, sometimes 1 to 2 weeks to plan. Whereas more simple treatments could be as short as same day or 1 to 2 days. And so you have to choose, right? In patients who have very high symptom burden, this might be a better approach. Whereas in other patients, it might make sense to wait for a more complicated plan. So when we think about some of the indications on this plan, are we talking about high symptom burden or low? Are we talking about patients who might live a longer time or a shorter time? Are we talking about the importance of local control, right? So in certain locations with high value real estate, including controlled disease, where we might be thinking about oligometastatic paradigms, it's really important to deliver a dose that might be more durable, right? So something on the higher end may be more appropriate to this side, whereas the lower end may be more appropriate to this side. Is it potentially a histology that doesn't typically respond as well to radiation? I'm going to cross out melanoma because this is it's kind of been called into question, but renal cell is probably the best example of a histology that we think of as radioresistant, meaning less responsive to radiation. On the other hand, radiosensitive tumors, ones that are killed very effectively with radiation, may not need as much dose. Are there options for systemic therapy or not? Is there an impact to a delay in systemic therapy, right? Is it one that we really need to get that patient back to treatment fast? And then this, and perhaps the most important, is saying, well, what are the burdens on that patient, both from a time perspective, from a cost perspective, from a family perspective? Many of these patients, as they proceed down the line of having more and more symptoms, as that performance status that I showed you on the last slide decreases, their needs on family and other caretakers and the health system in general increase. So every time we call them in for a fraction of radiation or to see us, it ends up really impacting them from a cost and an opportunity cost perspective. So let's say we have a patient who's going to live 6 months. Do we really want them to spend two weeks of those 6 months with us coming into the hospital every day? We have to have a really good reason to do so. But if it's a patient who might live 6 years, then maybe that 2 weeks is worth it. One of the really critical elements of palliative radiation oncology and palliative care in general is trying to estimate prognosis. And this is really hard because doctors in general are often rightfully maligned as being poor at being able to estimate prognosis. And it's not for lack of desire. I would say back in the more paternalistic era of medicine, there was less insight given to patients for perceived sensitivity reasons that patients shouldn't know or wouldn't want to know. Now I think patients do want to know, and as part of shared decision making, that is important. But at the same time, trying to really assess that in a predictive way is hard. So some doctors underestimate, and people will say, I defied all expectations, and sometimes they'll overestimate, and patients don't necessarily make the plans that they need to or enter hospice when they need to. So being able to estimate is an important capability, although our models including some of the ones that I've shown here, and I'll kind of go through one of them in greater detail in a second, but are imperfect. And I think they really sort of group things into buckets. And I think the buckets that I tend to think about are they potentially hospice eligible, right? Is it kind of very short life expectancy? Is it intermediate? Or is it long? And I don't mean long like decades. I mean long meaning closer to a year or more. A year or more doesn't sound like a long time, but in the palliative care context, it is. We always have to think about, in every situation, the risk-benefit ratio, right, of treatment. Right? We could look at it either way, either with benefit at the top or risk on the top. Actually, it'd probably be easier for the purpose of this discussion to reverse it, but remember, it's a ratio nonetheless, right? So obviously, we want the risk of our treatment to be low and the benefit to be high. So this overall arrow is pointed in the up direction. Some treatments, right, have some risk to them, but we know that they're going to get a bigger benefit, so it's okay. The problem becomes when there's a question mark. Is the patient going to get a benefit, and what the risk is going to be? And is that risk-benefit is not just one point in time. Is that risk-benefit, if I gave the treatment today, is it going to be realized in 6 months, in 3 months, in 3 days? And how can I mirror that or marry that with the potential life expectancy of the patient? So if I think the patient's going to live 6 months and they're not going to realize benefit from the treatment for 9 months, probably doesn't make sense to give that treatment. So this is really important in this whole context of trying to estimate where patients are on this continuum and trying to help guide patients. Patients are also interested in this in these figures, and it's always useful to have conversations about what patients would want to know, not from a predictiveness perspective, but from trying to paint a sense of what the future might look like, not necessarily as much in terms of longevity, but things you're concerned about. I think it's okay to have these conversations in terms of, I'm concerned about this, or this is what I think may happen, right? I alluded in my intro remarks about the hope but worry framework, which is one of the most useful frameworks I find in many aspects of life, right? Where you're trying to basically convey hope to patients. I hope that this will happen, but I worry about this. And I think this is a sensitive way to have discussions with patients that are able to focus on the things they want to focus on, while at the same time acknowledging certain aspects of the treatment. Okay, so the model that I want to look at is called the TEACH score, but there are a few different models that exist. They're all imperfect, but I just want you to take a look at these just to get a sense for a couple things. What do we define as short, intermediate, and long? According to these guys, they have sort of their 3 buckets, right? The Chow index has its 3 buckets, and this other risk index has a bit more granular component, right? But this gives you a flavor for what we're talking about. The more points you get, the worse your prognosis is. Sorry, I didn't mean to cross that out. This is 1 month. So on each of these things, when you get points up above here, that's generally bad. So the type of primary tumor, breast and prostate, tend to be the best in terms of natural history, whereas lung and others tend to have a shorter life expectancy. So you get a point for that. If your performance status is lower, right? And there are a couple of different ways to look at performance status, and I encourage you to Google the KPS and the ECOG if you haven't, and just to look and see kind of what are some of the elements there. Typically, an ECOG of 2 means you're in bed around 50% of the day. And so that does, as you might imagine, indicate a certain degree of debility from that particular disease. KPS is a bit more granular. It goes from 0 to 100 at 10-point increments and can be quite helpful there. Sometimes a very useful metric for performance status is just asking the patient the question, do you go outside, right? And these days, obviously, with social distancing, it may be less useful, but it can be a real indication as to whether the patient is bedbound, sitting on the couch all day, or able to actually just even get outside for a walk. It's a big thing. It seems simple, but it's a big thing. Can you get up and make yourself a sandwich, right? That tests you a lot. That tests a lot of things there, right? Tests for things like anorexia, tests for neurologic and cognitive function, and a few other things. Age, as you might imagine, how much systemic therapy they've had. You might think that I kind of was long-winded about the systemic therapy on a prior slide, but part of the reason I wanted to talk about that is just how important that is to assessing the prognosis of patients. And so in this case, you get additional points if you've had more chemotherapy. Where the metastases are located is a big deal. In this case, their model is hepatic metastases, but I would say in general, there's a big difference between having visceral metastases, meaning to organs, and typically by this we mean liver, right? Sometimes lung, brain, and others, right? Versus bone only, right? When they're bone only metastases, patients can live a bit longer. Have they been hospitalized in the prior 3 months due to this condition? That's certainly a big thing. And when you add this up, you can end up getting in these different buckets. And that gives you some sense. Now, these are nomogram that are based on data from patients. They're not predictive, but they give you a sense, and they make intuitive sense. So what do we talk about when we talk about possible symptoms that we see and that we treat with radiation? And I have some pictures I'm going to show you of some of these different things. And I purposely wanted this talk to be less about the symptoms, despite the fact that much of what we do when you see a patient as a palliative patient, typically as an inpatient, but sometimes as an outpatient, is focused on the symptoms. But it's so important when you're thinking about these symptoms in terms of thinking about the dose and fractionation, whether to treat, and the conversations that you're having. That says convo. That you're having of whether and how to proceed. And this is a really important thing. Okay, so one of the things that we will see will be cord compression, and I'll show you on a subsequent slide what that looks like. This is probably the best example of a radiation emergency because we want to basically embark upon treatment quickly due to neurologic compromise. It's like many of these can be a multidisciplinary management, but that's something that we tend to see. Pain in general, typically from metastases to bones or other organs, is a very common thing that we see. It's one that we want to treat, but it's also not something that's an emergency. Even in patients with severe pain, it's something that requires some degree of finesse. The reason being that for some of these patients who are going to live a while and you're treating multiple sites, you want to be very artful about how you deliver that treatment in such a way that you don't restrict your options in the future. One of the myths about radiation is that it can't be delivered twice. And that's not actually true. Even for higher dose treatments, we're finding more and more patients living longer and the need to potentially give those patients additional treatment. And the same is true with palliative treatments, that there's even more literature for being able to deliver treatments multiple times and kind of how to do that safely. Now, some patients, of course, when they're getting treatment to a new site in the body, it's not a big deal because they haven't gotten treatment to that site. But it might be a particular bony met, for example, that they need treatment. And as I mentioned to you, using a lower dose, we sometimes find that because we're not giving enough to kill every last tumor cell, that in 6 months or a year, that the patient comes back with recurrent disease in that area, and you can give them more treatment. If they require treatment shorter than that, within a few weeks, then it calls into question whether your treatment was effective or not. Brain mets are something that tend to happen pretty frequently in cancers, and because many of the systemic therapies don't tend to cross well into the blood-brain barrier, we often consider giving brain-directed radiation, which doesn't necessarily help with prolonging how long patients live, but they do help with preventing or minimizing neurologic symptoms from those tumors. There are other potential sources of obstruction or congestion. Sometimes this is gastric outlet obstruction or intestinal obstruction. SVC syndrome and other sorts of vascular congestion can exist as well. And so while these tend to be more urgent type things, they're not necessarily emergencies. Bleeding is another common indication, so this may happen in the GYN tract or GI tract where patients are bleeding, or even hemoptysis. And typically for this, I would say that radiation is a very effective scleroser of blood vessels, and so it does tend to work quickly, usually within 2 to 3 days. But as you can imagine, it's days, not hours or minutes. And so if patients have very severe bleeding symptoms, then this may not be the best approach. There are other thoracic symptoms like cough and dyspnea that we often see patients for, sometimes post-obstructive pneumonia. We'll see patients for. Post-obstructive pneumonia is basically where a tumor is obstructing distal airways. And one of the things that you'll learn about when you're on the wards, if you haven't already, is that things that don't get a lot of oxygen or things that are kind of walled off, places for fluid to collect, can become infected. And so post-obstructive pneumonia is one possibility there. Gastric symptoms I sort of mentioned in the context of obstruction and bleeding, and there's some others that sometimes that we'll consider treating. So all of these are potential reasons, including some others where we'll treat. There are other conditions like oligomets, like we talked about. There are benign conditions. There are other etiologies like splenomegaly, other large tumors, other things that we sometimes see that we get involved with. The doses, as I mentioned, can be quite variable, but usually somewhere in the 8 to 40 gray range is usually kind of what we're thinking about. There are some exceptions in both directions, but that's a usual sort of framework to kind of keep in mind. So to that point, these slides look at a few of the different indications by site from that paper, which are helpful. I'm not going to spend too much time on them now, but it does give you a little bit of a flavor for what some of the doses are. And you can see within each subcategory, so let's take, for example, this GI bucket here. It may be 30 gray and 10 fractions, which is a very standard and generally for most sites a pretty safe and effective dose for whatever the indication is. There are in each area opportunities to hypofractionate, I'm trying to underline, not cross out, where we could deliver the same effectiveness of treatment but in a shorter period of time. I think I've used the analogy with you before, but the analogy of a mortgage, right? So let's say I'm buying a $100,000 house. I could get a 15-year mortgage or a 30-year mortgage. And ultimately, the difference between these two is not going to be the house that I'm buying. It's going to be my monthly payment. So my monthly payment is going to be higher. So the monthly payment in this analogy is the daily dose, whereas it's lower with the 30-year. But over the course of the 30-year loan, I will have actually paid more money through interest and my payments, whereas the 15-year will be a little less. So to have two what we call equal effective radiation doses, a 30 and 10 may be similar to a 20 and 5, right? The daily dose for 30 and 10 is 3. The daily dose for a 20 and 5 is 4. But the overall dose is lower than the 30 gray dose, but these are both equivalent to each other. And in most of these, the same thing is true. There's some other published regimens depending on the site, sometimes given twice a day, which we can sometimes be reluctant to use in palliative patients just due to the inconvenience, but it can be sometimes helpful in getting them done quicker. You can see how the prognosis can be helpful in deciding which sort of treatment to pursue, and you can also see some of the symptoms that we spoke about. Here they do have a group for oligometastatic disease, and that's worth some discussion in one of the upcoming talks. So this is a picture here from a couple of pictures that you might have seen in one of my med student lectures before. This is just a picture, or this is a picture of cord compression. What you can see here is a tumor that's compressed in the spinal cord. So remember that the spinal cord is wrapped by a bony protective complex. These are the vertebral bodies. The whole spine, right? The whole spine is a combination of the cord, which sits in here, and the vertebral bodies which surround it and protect it. What you feel when you feel your back are these posterior spinous processes, the posterior elements. This is what you feel when you touch your skin. The spinal cord sits behind it, and as you know, in adults, typically ends around L1, maybe T12. And then you have the cauda that sits below that. Many tumors, because of the rich blood supply of the vertebral bodies, like to metastasize here. And so what happens is they go there and they grow, and sometimes it can cause the vertebral bodies to weaken and smush. And what happens then is that the bone starts to, instead of being where it should be, starts to squish backwards and squish on the spinal cord. That can cause cord compression. And as you might imagine, no amount of radiation is really going to help that because the bone is in a spot where it shouldn't be. It's like spraying termite killer after the 2x4 in your wall is already broken. It doesn't really do too much. It can help prevent things from getting worse, but it's not going to do the most immediate benefit. The other option is you have a tumor and it itself grows outside of the vertebral body and starts to squeeze on the cord behind it. And of course, because the cord, just like the brain, is in a very tight area, it has no place to go. And so squeezing on it directly can cause cord ischemia as well as inflammation. And it can cause neurologic symptoms of various sorts. And so by giving radiation and trying to kill this guy off, we can alleviate some of the symptoms of the cord. But remember, it takes 2 to 3 days, right? So if a patient needs something sooner, and in many cases, if it's a younger patient who's just developed symptoms, surgery might be the most appropriate option. But for many of these patients, as you might imagine, surgery is not really in the cards because of their functional status. And so we might consider giving radiation in that context. Remember your dermatome maps from neuro. And these are very helpful because, especially for a lot of these spinal cord lesions, the path of those spinal nerves can dictate a couple things. One is, in some patients, they may have what's called a spinal cord level, which means numbness kind of below that level or starting at that level. They may also have radiculopathies where actually squeezing on this nerve causes nerve-like pain to shoot down in the distribution of that nerve. So it might be that a patient who has sort of a sciatic lumboradiculopathy that's kind of tracing down the outside but stops above the knee might have an L4 lesion, right? It doesn't always correspond perfectly, but it gives you some pretest probability for where you might be looking with your imaging, especially if a patient comes in with new symptoms. One teaching point, which is sort of outside the scope of this course, is to always get a complete spine MRI. This kind of flies a little bit in the face of some of the stuff you'll hear in other lectures about appropriate imaging use and health economics. But I will tell you that in a patient who has these sort of symptoms, who potentially has cancer, it does them no good to be parsimonious about what you're going to order, because ultimately it could cause, it's cheaper to get a more expensive test in the short run than it is to do a bunch of sequential things that you could have just addressed at one time. What I mean by that is, let's just say I think it's an L4 radiculopathy and I just get a lumbar thing, but oh, wait a second, they have something in the thoracic spine too. I might have missed it, and that might cause a repeat hospitalization. And so it might be that I could treat two sites at once by looking at the whole spine. And sometimes it can fool you. It might be that the thoracic lesion is causing the symptoms, even though it looks like a textbook L4 lesion. This is an example of cauda equina syndrome, right? So this is the tumor here, squeezing on the cauda. Remember that when we're looking at the spine, right, this diamond-shaped guy's S1, L5, 4, 3, 2, 1, T12, T11. So the cord, the conus, looks to be right about here, kind of right about T12, right? And so below that is the cauda. And so as it's squeezing on this, we could have cauda equina syndrome, which is sort of the entity of the saddle anesthesia and some of the bowel and bladder difficulties and some of the things you've learned about in other contexts. This is an example of a brain met. You can see it pretty clearly here. Brain mets can really go anywhere in the brain, and some kinds of tumors are more likely to spread to the brain than others. They're often thought to sort of manifest at the gray-white interface due to changes in vessel caliber, but they can really be found anywhere, and sometimes can involve the meninges where you can get leptomeningeal disease. Sometimes we'll give stereotactic treatment just to this site. Sometimes we'll give whole brain treatment depending on the circumstance. Stereotactic treatment on that diagram that I showed earlier with the kind of two extremes is a higher dose, more complicated treatment that might be more appropriate to a patient with longer life expectancy, whereas in other situations, something quick and dirtier like a whole brain treatment might be more appropriate. This is an example of SVC syndrome, sort of in the chest where a central tumor is sort of involving some of the central structures in the chest and causing vascular congestion higher up. There isn't a ton of burden, at least that we can see here, there isn't a ton of burden of disease elsewhere, but this illustrates the point of location, just like in real estate, that even if you don't have a high volume disease, you can have a very large degree of symptom burden. You also can have a large volume of disease and a high symptom burden, or vice versa. There are definitely patients who come in who have widespread metastatic disease and very few symptoms, and vice versa, and everything in between. It's an example of airway obstruction and stridor due to met to the head and neck. Presents sort of in a patient who has a trach. Presents very similarly to epiglottitis in some ways that you might learn about in pediatrics. This patient is a bit more complicated because they have a trach in place and may be able to breathe despite this. And so this might be an indication for treatment. It might actually not be. So I don't, this is an image I got from elsewhere, so I don't actually know the patient's clinical history. So those are some examples of images, and I think that, by way of conclusion, what I would say is that I think that 30 to 50% of patients is a fair number for palliative care. I think we talk about the treatment of symptoms. We want to maximize the risk-benefit ratio, keeping it as high as possible. We want to think about estimates of prognosis and marrying the risk-benefit to that. Remember, the risk-benefit ratio, as we spoke about, is not static. The risk-benefit ratio over time this is risk-benefit ratio. For different cancers in different people, it may change. So it may be that this time we're looking at the arc of treatment. It may be we're just looking at pure time, saying that the risk-benefit ratio is highest now but lowest later, or vice versa. It's something that we have to constantly sort of reassess, right? What does that curve look like? Is it linear? Does it have some irregular shape? And it really sort of depends on that particular patient what that might look like. I think the emphasis is also on models of prognosis and how that impacts conversations that we have with patients, and trying to estimate prognosis, and not to underestimate, not to overestimate, but trying to sort of help patients decide. Patients, despite the emphasis on shared decision-making, which of course is important, it can be hard sometimes to really be able to paint the picture with patients as to what the future may look like. A, because you don't know, and B, because it can be hard to explain sometimes. And it's not for lack of trying, but because it can be hard to describe to a patient what they might feel like closer to when they're peri-hospice versus when they're initially at diagnosis. And so sometimes it is important to have those conversations in a way that you might be needing to be more directive in a way of helping guide them down a particular course of treatment if you feel that perhaps they need some reorientation. We talked about some specific syndromes and images. I think it's probably less important to focus on those, but just to get a flavor of some of the things that are being treated. Some of the dose ranges are probably worth considering, that the less than 40 gray, but typically 30 and 10 or less kind of being a very effective palliative regimen is worthwhile to consider. When you see a patient being treated with 30 and 10, I think you have a general sense of what the intent of treatment is going to be. But increasingly, as we kind of look between the 30 gray range and the 60, 80 gray range, there are definitely some dose ranges in between, and there's some patients who are palliative patients and some patients who are definitive patients. I want to close this by impressing upon you And this is probably true in any field of oncology, but potentially in any field of medicine, is to really define, especially in the oncology world, what your intent of treatment is. It's important, I think, to be very specific. Whether your intent of treatment is definitive, and definitive really means for cure, right? Curative, I tend not to use the word curative, not because that's not what we're seeking, but because I think curative implies some degree of prediction. I think definitive means that we stand that chance. The other option is palliative. And it doesn't mean that the patient is dying immediately. In a way, we're all dying, but the patient's not dying immediately. The question is it going to be something that's not necessarily going to impact the trajectory of their disease like a definitive course would, but is very focused on alleviating a particular symptom or preventing a particular symptom. That distinction, I think, is really important in helping to decide what the risk-benefit ratio is, whether you need to treat or not, what the patient's prognosis is and how that impacts things, marrying it to any symptoms that they have, and potentially picking your dose, right? And that dose may be 0 in some situations. Okay, thank you so much.